A 15-year-old self-identified Hispanic girl is brought to the outpatient adolescent medicine clinic by her mother due to concerns that she has not yet experienced her first menstrual period. Patient reports that she's never had a menstrual cycle, and she notes that most of her periods at school have already begun menstruating. All right, so here it seems like we're evaluating for a primary amenorrhea kind of a concern, so we'll make sure we highlight that. And her mother reports that the patient has had a normal appetite, has never restricted her caloric intake, and does not engage in purging behaviors or excessive exercise. Okay, so that kind of rules out some of those functional amenorrhea kind of concerns where, excessive purging or low appetite or low caloric intake can suppress the HPA axis a little bit. Continuing here on physical exam, her height is in the 3rd percentile for her age. Her weight is in the 45th percentile, temperature is 98.1, heart rate 74, respiratory rate 14, blood pressure 134/86. So from a vital standpoint, she's doing fine, but this short stature here is quite concerning. Inspection of the neck reveals a low posterior hairline, lateral skin folds extending from the mastoid process to the acromion. Cardiopulmonary examination reveals a regular rhythm and early systolic ejection click at the left upper sternal border. Musculoskeletal exam reveals an increased bearing angle of her elbows bilaterally. Sexual maturity rating demonstrates Tanner stage 1, breast development, Tanner stage 2, pubic hair distribution. Initial lab values demonstrate FSH of 68, LH of 34, TSH of 2.1, serum prolactin of 12. Which of the following diagnostic studies is the most appropriate to confirm the diagnosis? So, given some of these findings here, what the concern here that is important to understand is that this is a primary amenorrhea, and then these lab values tell us sort of if it's a problem at the ovaries or if it's a problem at the pituitary gland. And so these hormone levels being elevated tells me this is more like a hypergonadotropic hypogonadism. It seems like the signal from the brain is all right because those levels are perfectly normal, if not elevated, but there doesn't seem to be this menstruation that's happening, which means that the ovaries are not responding to the signal adequately. And it seems like the thyroid and the prolactin are both within normal, so it's not like there's a hyperprolactinemia from like a pituitary tumor that's driving it, and nor is there a hypothyroidism that can also suppress because of the effect that it has on the hypothalamus. So, that kind of rules out the thyroid or prolactin kind of concern. But, in a 15-year-old with, not having developed secondary sexual characteristics, we would be concerned for primary amenorrhea. So which of the following diagnoses is most appropriate to confirm the diagnosis? So the diagnosis here should be leading us towards possibly Turner syndrome, and the reason why is that we have some of the findings that would be suggestive. So primary amenorrhea being one of them. This patient has a short stature, which is classically seen in Turner syndrome. Furthermore, there's oftentimes a webbed neck that is seen, and you can Google images for this, but it seems like that's what they're trying to describe here in this vignette with this low posterior hairline and the lateral skin folds. Furthermore, you would see this hyperangulation of the elbow, so it's called cubitus valgus, but it's likely what they're describing here with this increasing carrying angle of her elbows. Furthermore, you would have a bicuspid aortic valve be one of the things that's high risk in a patient with Turner syndrome, so it's likely what this systolic ejection click murmur is being described here as. And then lastly, we would know that if there was a transvaginal ultrasound done on this patient, you would see some kind of streak ovaries or some kind of fibrosis overlying the ovaries, and that would be all the things that you would look for as relatively high yield to remember about Turner syndrome. And if you remember, Turner's is going to be a 45XO because there's a problem with the X chromosome, and there's many different causes that can lead to it. Mosaicism is one of the general terms used to describe this defect in the second X chromosome here. And so just working through these answer choices, sort of a fish for the SRY gene, you would do this if you're concerned about some problem with the Y chromosome, and we've already established that this is most likely leading us towards Turner syndrome, where there's a problem with the X chromosome, not the Y. Measurement of serum 17-hydroxyprogesterone concentration, so you would do this in the case that you're concerned for congenital adrenal hyperplasia, and you would see signs like ambiguous genitalia at birth or even virilization kind of findings. Doesn't seem like that's what's being described here either, and so we can sort of move past that. Peripheral blood karyotype analysis, so this is exactly what we're looking for. We want to be able to do the karyotype and look for this 45XO that would essentially confirm the diagnosis, and so C would be the correct answer in this case. Moving on, though, the serum total testosterone level, this would be useful if you're concerned for androgen sensitivity. The only difference being in a patient with androgen sensitivity, you would actually have normal breast development, so instead of Tanner stage 1 breast here, you would see Tanner stage 3 or 4 because you would have aromatization of all the testosterone that's being secreted to estrogen peripherally, and so since that finding is not really consistent, furthermore, you don't have all these other features that I described that would be consistent with Turner syndrome. And then lastly, skull MRI, this is something you would do